Hello, I'm Dr. Park from Boa Dental Clinic. Thank you to everyone who took the time out of your busy schedule to join this live surgery. Today's case involves immediate implant placement in the posterior region using the bright tissue level implant. Let me first tell you about the patient's information. The patient is a 73-year-old female. She visited our clinic with the chief complaint of discomfort when using a water pick in the upper left posterior area. The left maxillary premolar and molar were connected with a bridge, and secondary caries was observed. On the X-ray, we can see severe secondary caries on the upper left second molar, and extraction was planned. But from the X-ray and intraoral examination, it was difficult to determine the exact treatment method for the upper left first premolar. Although significant alveolar bone loss was observed, there was no mobility because it was connected by the bridge. Therefore, we discussed with the patient that we would evaluate the prognosis of tooth 24 after bridge removal, and then establish the final treatment plan. After removing the bridge and evaluating, we found deep root caries and severe mobility of first premolar, so decided to extract the tooth. After extraction, we planned to place 3 bright tissue level implants at sites 24, 25, and 27, and fabricate a bridge type implant prosthesis. This is the same X-ray. For 23, we decided to redo the crown after bridge removal. This is the preoperative CT. As you can see, the available alveolar bone thickness at 24 and 25 was approximately 5 millimeter, maybe less than 5 millimeter. This thickness is insufficient even for placing a typical narrow diameter implant. In this situation, there are several options. We could attempt ridge splitting, but it was not simple. Or we could place a regular diameter fixture and perform bone grafting on the dehiscence defect or fenestration defect. It was not simple too. There is simpler method, so I decided to place the thinner and stronger bright tissue level fixture and perform bone grafting on the buccal side for thickening buccal bone. For the 27 side, available bone thickness and the height was sufficient. I plan to achieve good fixture fixation and perform bone grafting in the remaining extraction circle area. Immediate implant placement after extraction. Yes, these are the before and after photos of bridge removal. We can see that the second molar has only residual roots remaining. 25 looks fine in the photo, but the distal root caries extended deep below the gum, and there was mobility, so we decided to extract it. In today's live surgery, I will use the bright tissue level fixture. As you may know, this fixture is highly effective for a narrow area. And bright tissue level implants are stronger than internal type implants of the same diameter, allowing the use of thinner fixture. And the bone graft material I will use today is osteointhric collagen. It was a synthetic bone material where 60% hydroxyapatite stably maintains the space and 40% beta-TCP promote bone formation. The bone graft material is bound together with 8% collagen, which provide excellent handling properties. And I will also use a collagen graft in today's surgery. It is mainly used to fill the extraction socket with soft tissue when performing the open membrane technique or to augment the thickness of gingiva. Let's look at a case similar to today's surgery. This patient visited due to pain in tooth 47, complaining of a periapical lesion and pain. Pain during mastication. Retreatment of the root canal was deemed difficult, so we plan to extract 47 and perform implant surgery at site 45 and 46 because of severe periapical bone loss of 47. You can see that the bone width at 45 and 46 is narrow because of absence of tooth. In this case as well, we decided to use the bright tissue level implant. Yeah, these are the clinical photos. You can see that the bone width at the 45 and 46 site is narrow. After raising the flap and drilling in the conventional method, installed bright tissue level implants and collagenated bone was grafted on the buccal side to augment the thickness of buccal bone, though there's no dehiscence defect. After 2 months of healing and then fabricated the prosthesis using a tie-base abutment. You can see that 2 implants have been placed at the 45 and 46 sites. At the 45 site, 4 mm diameter bright tissue level implant was used. And since the bone was thinner at the 46 site than 45 site, 3.5 mm diameter bright tissue level was placed with bone grafting on the buccal side at the 46 site. This is a photo after the prosthesis was completed. Okay. From now on, we will proceed to watch the surgery. I'm making an incision using a number 15 blade. You can either extract the teeth first and then raise the flap, or raise the flap first and then extract. I prefer to raise the flap first because if you extract first, the flap may get slightly damaged during the extraction procedure. And in case of retained roots, such as tooth 27, raising the flap first allows better visualization of the boundary between the tooth and the alveolar bone, which makes the extraction easier to perform. While it may not significantly affect the overall surgical outcome, if the flap is damaged, the patient may experience greater post-operative discomfort. During the incision, the patient said she felt the pain, so I give more anesthetic shot. 여기 지금 만지면 아파요? 불편한 왼손 드세요. After anesthesia, yes. Okay, going incision. When raising the flap, now as you can see, I frequently use a curette. No matter how cleanly we make the incision using blade, if the underlying bone is irregular, the periosteum often cannot be completely incised with the blade alone. In such cases, if you try to raise the flap using only a periosteal elevator with force, it ends up causing significant trauma to the flap. The flap does not open well, the surgeon struggles, and the patients may experience more postoperative pain and swelling. Once you draw the incision line as cleanly as possible with a blade, then use a curette to sever the periosteal attachment along the irregular bone beneath the incision line. The flap will open on its own, like that. Some dentists use a mold curette for this purpose, and the various instruments can be used. So I prefer the curette. The important point is that when raising the flap, if the periosteum is completely incised, the flap opens very easily. After raising the flap, now extract the tooth. 24. Using the elevator. Yes, I extracted 24 teeth, and now I extracted the 27 retained root. Please understand that there is quite a bit of movement in the video as camera is mounted on my head during filming. While fixing the camera externally eliminate moving, the posterior teeth are not captured well on camera. By mounting the camera on my forehead as like this, we are doing now, I can accurately capture exactly what I see. However, the video shakes when I move my head. Okay, now I am going to extract the 27 retained root. Yeah, at the 27 extraction site, we will install the implant immediately. One of the most important thing for immediate implant placement is completely clean in the socket. Yes. After extraction, now raise the palatal flap using curette 2. Generally, new curette I use for perio treatment, and old curette with blunt blade is used for like this flap elevation. We are now drilling at the 24 extraction socket site. First, the 2.5 millimeter drill is used, and followed by the 3 millimeter diameter drill. Yeah, drilling is completed with just a 2 sequencer drill, because I will use 3 millimeter diameter fixture. The 3 millimeter diameter bright tissue level implant is being placed in the 24 extraction socket. The placement depth should be set so that the rough surface of the fixture is fully submerged within the alveolar bone. And I think the platform margin is positioned at the subgingival level. Now I evaluate the site of 25 implant and drilling for 25. 2.5 diameter drill first. Sorry for moving because the camera is on my head. Yeah, next 3 millimeter diameter drill. And I will install the implant 3 millimeter bright tissue level fixture. Implant is also being placed at the site 25 using the same drilling sequence as 24. Yeah, now install the 3 millimeter diameter and check the direction of fixture and keep put in the bone the fixture. Since the bone width in the 25, 24, and 25 was only less than 5 millimeter, drilling was done with careful positioning to avoid dehiscence. From now on, I will now drilling at the 27 extraction socket. When drilling in a posterior extraction socket, drilling is usually done on the septum, and it is important to secure the position well to prevent slipping. The initial drill of Bright system is a Lindemann drill, which is excellent for preventing slipping in such cases. 아프세요? 걸릴 수 있으세요? 그럼 한 번만 네.
달달 올리고 물 많이 들어갑니다.
Since the bone width was wide, a 4.0 millimeter fixture was used for 27. A thicker fixture could also be used, but I believe 4.0 millimeter is sufficient for the bright tissue level implant in the posterior region. Let's check the drilling site. Maybe 4.0 diameter drill.
달달 올립니다.
Yes, now I'm installed a fixture 4.0 diameter bright tissue level fixture. And the 27 site, because it is immediate implant placement, there's no sufficient fixation, so I planned submerged the 27 implant. After fixture placement, bone grafting is performed on the remaining area of the extraction socket using osteointegral collagen. Collagenated bone make the handling easier. And the bone grafting 2 and 24 extraction socket area. Before suturing, although the dehiscence defect did not occur at site 24 and 25, the remaining buccal bone is thin, so there is a possibility of future resorption. Therefore, bone grafting was performed on the buccal side using osteointegral collagen. Since the role of this bone graft material was intended to partially form bone and prevent resorption of the buccal bone, a barrier membrane was not used. Just bone grafting. Of course, if a barrier membrane was also used, greater alveolar bone augmentation would be expected. In this surgery, since we did not expect all of the grafted material on the buccal side to convert to the bone, the graft was placed with the assumption that approximately half might resolve. 오늘 IPTI 7번은 안 하고 4번까지 발치해서 컨트롤이가 좀 있어야 되겠어. 누르지 말고 올라오세요. 3번은 어차피 3번이 없어서 3번을 오늘 끼우나요? Okay, after fixture installation and the bone grafting, I do the straw. In this case, because I didn't use the barrier membrane, the suture is a little easy. 살짝 무세요. 네. Okay, now I made a suture between 24 and 25 implant. 위치 괜찮아요? 콜라겐 그래프트 줘. 그냥 줘. 가운데 구멍 뚫고. For the 27 extraction socket, collagen graft was placed over the top to allow open healing. I made the hole, the collagen graft, to for cover screw, but it's not working. It didn't work. Yes, suturing was done with the goal of open healing rather than primary closure. Maybe at the figure of H2. No, not figure of A. Yeah, this chair fixed the collagen graft. And collagen graft prevent the bone graft material in the extraction socket. 볼까요? The collagen graft maintain maybe for 2 weeks and until 1 month during healing period. But according to my experience, when the patients have severe periodontitis, often the collagen graft resolved faster. Okay, maybe the 27 side suturing is done, and I will suture at 24 side. And the 24 side is also immediate implant placement in extraction socket. So as 27 site, I will use the collagen graft. For fabrication of provisional prosthesis at 24 and 25, I will connect the skin body to 24 and 25 fixture. Okay, now connected the skin body to 24 fixture. Maybe I want to change the position of decut of skin body. So reconnect the skin body of 25 fixture. And the 24 implant site, I will I used the collagen graft to cover the remaining extraction socket area. During the healing period, the collagen graft resolved slightly, slowly, and new soft tissue will be filled there. I tried to fix the collagen graft. I used one more silk for one more suture. To fix the buccal collagen graft, I suture like this. The silk press the collagen graft like that, maybe shape of X. Okay, the surgery was completed. You can see that the fixture have been well placed at the 24, 25, and 27 sites. You can see that scan bodies are attached at 24 and 25 for fabricating provisional prosthesis because of aesthetic problem. This is the post-operative CT. At 24 and 25, we placed the Bright Implant with a 3 mm diameter. Thin and strong fixture are advantageous in area with thin bone, like this. Thin implants are usually made in one-body implant form, which is disadvantageous in terms of prosthetic options. Whereas the Bright Implant is thin, but comes in a two-piece form, so there is no disadvantage in prosthetic method. Even if the implant is placed at the correct angle in thin bone and no dehiscence defect occur on the buccal bone. Thin buccal bone can resorb over time, so bone grafting was performed on the buccal side. For 27, the fixture was secured in the center of extraction socket and bone grafting was performed. As mentioned earlier, fixtures were placed at the 24, 25, and 27. Looking at the 25 site, if the fixture were just slightly thicker, if the fixture were just slightly thicker, like 4.0 fixture, maybe dehiscence could easily occur on the buccal bone, I think. Immediately after surgery, scanning was performed on 24 and 25 to fabricate immediate provisional teeth. For the 27 site, after bone grafting in the extraction socket, the Bright Implant was placed and the extraction socket was covered using a collagen graft. Because of insufficient insertion torque, as I mentioned earlier. This is the photo at the time of stitch out. Overall, the healing has processed well. And the collagen graft is maintained well. Okay, let's look at the question. The first, why did you choose Bright tissue level implant 3.0 millimeter for the 24 and 25, and the Bright tissue level implant 4 millimeter for 27? Yeah, as I explained during the surgery, the available bone thickness at the 24 and 25 was only about 5 millimeter. Therefore, it is best to place the thinnest implant possible. However, internal tie fixture have a limitation in reducing the fixture diameter because the abutment and screw must fit inside the fixture. And if the diameter is reduced too much, the outer wall of the fixture becomes too thin, creating a risk of fracture. Therefore, in such cases, thin and strong bright tissue level is an ideal choice, I think. The bright tissue level is available from 2.0 millimeter diameter fixture, but since this is a posterior area, they need to withstand occlusion force. So I used 3.0 millimeter for 24 and 25 site and 4.0 for 27. Second question is how will you use osteoarthritic collagen and collagen graft in this case? I will use osteoarthritic collagen in to fill the extraction socket after immediate implant placement. Osteoarthritic collagen or the osteogenecollagen is collagenated bone is make the GBR easier because the handle of the bone graft is easy. So I prefer. And the collagen graft, I use the collagen graft in this case to cover the bone graft in the extraction site after immediate implant placement. Yes, this is end of my presentation. I hope to help your clinic. Thank you very much to join us.